care. Usually, palliative care, as far as MRCP is concerned, it is about the onco care. So, very less questions will be there from dementia and post dementia care, but usually they will be around palliative care. So, analgesia, sedation, and when to let go. So, not exactly the end of life, but when to let go. That is included in the palliative care. So, let's begin with the first question. A 52-year-old woman with metastatic breast cancer and bony metastasis is taking hydromorphone for pain, but still is experiencing back pain. Now, she is reluctant to take more of hydromorphone because then she becomes more drowsy with higher doses. This group of medications is particularly useful for pain from bony metastasis. Hence, which is the likely treatment of choice? Is it the non-steroidal anti-inflammatory drugs? Is it the opioids again, which she is already taking? Is it the amphetamines? Are the anticonvulsants which are used for pain control? Phenothiazines, butyrofenones, or steroids? So I'll give you a while to just grasp the question. So basically, they are asking that there is a patient who has a metastatic breast cancer. We are not treating this patient, but we are just making their life a little better by giving them painkillers. So she's already on opioids. Now, the thing is that when she increases the doses, she becomes drowsy. So, is there anything else that we can add on to the treatment which can make her life a little better? So, the answer here will be non-steroidal anti-inflammatory drugs. Now, we cannot give other drugs because they will lead to drowsiness. And we definitely will not give steroids unless the patient has Kodak-Vina syndrome. So unless the patient has Kodak-Vina, quadriparesis, paraparesis due to bony metastasis, steroids are not indicated for pain control. So the answer here is A, that is non-steroidal anti-inflammatory drugs. Why? Because prostaglandins, they play a role in the bone resorption in metastatic disease. Hence, the explanation of and effectiveness of NSAIDs for this type of pain. Along with that, we also know that aspirin has been shown to have an anti-tumor effect in an animal bone tumor model. So the carry-home message is that if a patient has a bony metastasis and the patient is on opioids, you can use NSAIDs because non-steroidal anti-inflammatory drugs are exceedingly well tolerated and effective in patients with bony lesions. That is why in arthritis, in post-operative bone surgeries, the NSAIDs are the drug of choice. So, because bony metastases are there and the pain is also due to bony mets, hence, over and above the opioids, we can add prostaglandin inhibitors, that is, non-steroidal anti-inflammatory drugs. All right. Another question on similar lines, a 74-year-old, a very old man, 74-year-old man with metastatic prostate cancer develops shooting pain in his left leg and constant back pain. So this is radiculopathy. Further evaluation reveals a pathological compression fracture of the lumbar spine and involvement of the nerve roots in his lower spine causing pain. He is started on a medication to help reduce the symptoms, but the limitation of the drug is leukopenia and thrombocytopenia. For this patient with metastatic cancer pain, the likely treatment of choice is what? Non-steroidal anti-inflammatory drugs, opioids, amphetamines, anticonvulsants, phenothiazines, um, butyrofenones, or steroids. So we have a patient who has a compression fracture. Now, this compression fracture has led to the new onset of pain. Now, The problem is that we are going to be talking about a drug which causes leukopenia and thrombocytopenia. So let's see. So the answer likely here is the anticonvulsants. The drug of choice is carbamazepine, Tegretol. It is available with the name. It is an anticonvulsant which is also used as an adjuvant analgesic for neuralgic pain caused by either tumor infiltration or by surgical traumatic nerve injury. Because cancer patients commonly have compromised hematological reserve, leukopenia, and thrombocytopenia, which are the hematological disturbances caused by carbamazepine, may limit its use because these patients on chemotherapy may have both anemia, thrombocytopenia, and leukocytopenia. So, MRCP people are in a habit of asking twisted questions. So, they could have asked directly, but then they gave you a hint that the drug that we are talking about has got hematological disturbances as a side effect. So you will need to know that I want to mark carbamazepine or anticonvulsants as a option. Is that clear? These two questions very similar but with very different answers. So one was bony metastasis, where we know that after opioids, NSAIDs would take over. And then there is another patient with an acute problem, neuralgic problem, compression fracture leading to neuropathy. Now, I can give you another scenario in which a patient had a prostate cancer and suddenly developed shooting pain followed by anesthesia of the this pudendal area. So the patient is now having urinary and fecal incontinence. So what will be the drug of choice there? Anyone? What does this mean that a patient who has prostate cancer developed a vertebral compression fracture followed by urinary retention or bowel incontinence? What does this mean with not being able to move their legs also? What does this mean? This means Kodak-Vina syndrome. So in Kodak-Vina syndrome, the drug of choice will become option G, that is steroids. Okay, so that is the extension of this question. All right. So we will find out next question. A 68-year-old woman was treated for melanoma 3 years back. She now presents with constant headaches, nausea, vomiting, and left sided weakness. A CT scan done reveals two masses in the right parietal lobe consistent with metastatic melanoma. So she started on palliative care, that is, medication to reduce her symptoms. With symptoms, headache and nausea. For this patient with metastatic cancer pain, select the most likely treatment of choice. Now we have a lesion which is present in the brain and is causing compressive symptoms due to edema, perilesional edema. So the answer will be steroids here as well. So the answer is steroid. Steroids are useful for controlling pain with leptomeningeal metastasis or headache from increased intracranial pressure. So steroids will become indicated here. If there is a bony metastasis, NSAIDs. If there is a compression fracture leading to pain, answer is carbamazepine. Bony fracture, compression fracture leading to Kodak-Vina syndrome, steroids. Brain or cerebral metastasis causing edema, perilesional edema, and causing increased ICP leading to headache. The answer is steroids. Is that clear? So you will need to make these answers there, and unless you are prepared beforehand for all the indications, you may not be able to jump to an answer right away. Oh, okay. Next question. A 65-year-old man has a history of metastatic lung cancer and severe bone and chest pain. He started on morphine and ibuprofen. So ibuprofen is again NSAID to control the pain, but is still not comfortable. Further, gradual increases in the morphine dose, they do achieve good pain control, but he becomes drowsy on appropriate dose and unable to do much. He started on a medication that is useful in controlling opioid induced sedation. For this patient of with metastatic cancer pain and opioid induced sedation, what is the drug of choice that can be used that controls opioid induced sedation? Anyone? Anyone? Can anyone tell me what is the possible answer? And if you have understood the question is about somebody who has a metastatic cancer and is having pain, which is relieved with morphine. The only thing is, morphine makes him drowsy. He does not want to let go of the analgesic effect, but is asking you, is there any medicine which can decrease the sedation of morphine but keeps the pain of analgesic effect of morphine as such? Are you aware of any such medication which can decrease the sedation of morphine? Anyone?
Generally, which is used in yeah, uh, attention deficit hyperactive disorders. No?
Very good. Very good. So that is amphetamines. So the amphetamines, they are the drugs of choice. So the answer here will be amphetamines because the sedation of opioids can be controlled by either altering the dose or changing to some other dose or by adding amphetamine or methylphenidate or caffeine to counteract the sedative effect of opioids. So this is very important because the patient has metastatic bone cancer. You have tried everything. After opioids, you've added NSAIDs already, but the pain is still there. You want to increase the dose, but the patient does not want drowsiness as a side effect. The question then arises, can I do something to decrease the sedation? Because otherwise, pain relief with opioids is just wonderful. So, can I do some things? Yes, I can do. I can advise the patient for using these amphetamines, methylphenidate, or even caffeine can be useful in such patient. All right.